To summarize my presentation at EADO regarding AGCC staging and beyond, I will be talking about the use of sentinel node characteristics to determine prognosis. And there are many different ways to assess sentinel node tumor burden, but what is basically coming out is the most frequently used is the Rotterdam criteria, which is the maximum diameter of the largest lesion. This has been adopted by the EORTC melanoma group. And what we've seen is that it is also the most reproducible factor between pathologists. And one of the important aspects is that the threshold of 1 millimeter seems to be a very good threshold to consider patients with a stage 3A melanoma to have high risk or low risk disease. And therefore, it was also used as an inclusion criteria for the adjuvant therapy trials to have a stage 3A melanoma with at least 1 millimeter of tumor burden within their sentinel node. So we've seen now that adjuvant therapy is safe and effective for those 3A patients with 1 millimeter sentinel node tumor burden, and that the number then needed to treat to prevent one recurrence from happening is about 10. So that means that if you go to even lesser tumor burden in the sentinel node, you'll need even more patients treated to have the same benefit. We in the Netherlands, therefore, do not consider patients with less than 1 millimeter sentinel node tumor burden as 3A for adjuvant therapy because we don't think it weighs up against the potential toxicity to patients and also to the financial toxicity. In the session, there are also other presentations from AGCC, from Jeff Gerschenwald, and also from Daniele Massi, a pathologist from Florence in Italy, also looking beyond the AGCC staging that we have right now, and looking also at the use of gene expression profilers to even further specify the prognosis. That is still something for the future. So in the meantime, I think the sentinel node tumor burden, according to the Rotterdam EORTC criteria, are the way to go.